Welcome to another episode of Lessons from the Lab. I'm Devin Rubin from Mayo Clinic in Jacksonville, Florida, and it's good to be back with you again for a new episode of Lessons from the Lab. It's been a while since our last episode. It's really been a couple of months since I had a guest on, and since then a lot has happened. We've had the AANEM annual meeting in Savannah. It was a fantastic meeting, and I hope those of you who attended the meeting are applying the knowledge that you learned in your day-to-day practice as you help patients in clinic and EMG lab and performing neuromuscular ultrasound. It's a phenomenal meeting. I always learn something from that, and it's great to see everyone and meet new people as well. So since it's been a while, before we get to our guest, I'm going to add in a little bit more content here. I'm going to give a brief teachable moment. And yesterday, I was in our EMG laboratory. I was bored. I didn't have a whole lot to do over lunch. I was just kind of waiting for something to do. So I thought I would do some nerve conduction studies on myself, make sure I don't have any type of disease. And so I set up the electrodes on my median motor APB, and I was a little tired, so I was decided I'd stimulate my nerve to wake me up a little bit. So this is what I recorded when I did that. I'm going to show you the screen. This is my median motor response stimulating at 50 hertz. And for those of you who have never performed 50 hertz stimulation on yourself, if you're performing this on patients, you probably ought to do it on yourself. It's good to see what your patients are experiencing and see what it feels like. So this is my 50 hertz stimulation of my APB for about a half a second. And boy, it looks like when I do this, I wonder if I have Lambert-Eaton myasthenic syndrome. It looks like I have a significant increase in my amplitude from the first shock to about the fifth or sixth shock. The amplitude increases by about 15%. So do I have Lambert-Eaton syndrome? Well, I do feel fatigued at times. I do feel tired, but I don't think I'm that weak. So I don't think I have this. And this is a nice example of pseudo facilitation. And if you notice when you stimulate in a normal person at rapid rates, you'll notice the amplitude does increase slightly, but the area or the area doesn't change a whole lot, and the width or duration of the CMAP narrows some. And you can see that a little bit better on this second slide. This is also me. And you can see what happens at a slower sweep here, that you can see the individual waveforms and you see how the duration narrows as the amplitude goes up. And that's classic for facilitation. In true presynaptic neuromuscular junctions like Lambert-Eaton syndrome, you won't see that shortening of the duration as the amplitude increases. And this pseudo-facilitation is thought to be due to synchronous firing or contraction of the action potentials along the muscle fibers due to the rapidity of the stimulation. And this doesn't really show a whole lot of increase in amplitude. It's about 15%. Sometimes we see a little bit more than that. But it's an important point to keep in mind. If you're performing rapid stimulation, you see a slight increase in amplitude, that doesn't mean it's disease. So that's a little teachable moment. It was kind of fun. I actually wasn't bored. We were very busy, but I was trying to get a nice picture of pseudo-facilitation here. So I hope you learned from that, but I'm really excited to learn from our next guest. I have a wonderful guest. I have a challenging case for me, and hopefully she will help enlighten me in what this patient might have. So sit back and relax and enjoy this episode. Well, welcome to another episode of Lessons from the Lab. It's a great pleasure to introduce a wonderful guest today, a special guest, Dr. Lisa Hobson-Webb. Dr. Hobson-Webb is a professor of neurology at Duke University. She's an expert in neuromuscular medicine and neurology and EMG and neuromuscular ultrasound, and she's an all-around wonderful person, and it's a pleasure to have you. So thanks, Lisa, for joining in.
Thanks for inviting me. It's a really kind introduction. I always cringe a little bit when I hear myself described as expert in anything, but no, thanks for inviting me. And I've watched a couple of the prior episodes and learned quite a bit from them. They're great.
Well, thank you. I'm sure, and you are an expert, and I'm sure this is going to be great because I think what the listeners and watchers are going to want to hear what you have to say when I present a case to you, and I want to hear too because I always learn from these. It's really kind of educational for me as well. So, and I saw you. It hasn't been that long. We were at the AANEM meeting, running around doing a million things. Did
Yeah.
you enjoy the meeting?
Yeah. I thought Savannah was a great location for the meeting. A lot of great plenary sessions, posters. The abstracts were great, and I always try to do courses and things that maybe I don't have as much experience or exposure to. And one thing I really enjoyed this year was Dr. John Moran, his AI course that he did. And since I've been back, I've been trying to think of ways to implement that and what we do here in the clinic and EMG lab.
Have you figured out how to implement it yet?
I know I'm still like struggling through making a figure with Chat GPT. So
Okay.
I'm getting
Well,
there.
you're ahead of me because I don't even have Chat GPT yet. So you're way ahead of me.
Well, I learned a lot about all the different platforms and how, each of them differed a little bit, but I think there's some potential there to help us out in
Yeah,
neuromuscular
yeah.
function.
I think thinking it's not going to help us or it's not going to be
Yeah.
something used is it's probably not correct. So, well, good. Yeah, I mean, it was a great meeting. The thing I I wish I had time to go to a lot more things. There's so many wonderful sessions and workshops, and
Yeah.
that's the problem when there's just
Yeah.
not enough time.
I dropped in on part of one of your sessions because it was one of those time slots where there were three different things I wanted to attend all at once. And always learn a lot from your EMG talks.
Oh, well, thank you. Well, I look forward to seeing you at many more meetings, and it'll be like we'll blink our eyes and there'll be another meeting in like two blinks of an eye.
Yeah, San
So
Francisco, I think.
that's
Yeah.
right. That's
Yeah.
right. So,
Looking forward to it. Yeah.
well, we're gonna have our own little meeting here. So as you know, you've seen a couple of these episodes. I'm gonna present a case um, that we had in the EMG lab. I did the EMG on a little while ago, and it's a patient of my colleagues, and you're a smart person, so I'm going to give you a little challenging
Oh
patient.
no.
And this is not like the board exam. So, are you too young to take the oral boards?
No, I'm really old. I did the oral board exam.
Okay. So
Yeah,
remember they
but
tell you on the oral boards, it's not about getting the correct diagnosis. It's about the approach to the patient. And
yeah.
this is kind of like it. Because I'm not sure we know part of the diagnosis. So
Oh
it'll
gosh.
be
Yeah.
interesting to see what you think about this. So let's get to it. I'm gonna share my screen.
Okay.
And so let me make sure I do this right. Okay. Can you see that? Can you see my
I
slides?
can. Yeah.
Okay. Let me
See.
know if they go off for some reason. I was doing one of these lessons from the labs. And after 20 minutes of showing the screen, the guest said, I can't see your screen. So make sure if you tell me if it goes away. So
Okay.
basically, I'm going to just read this for the people who are listening. The patient that I'm presenting is a 52-year-old man who has type 2 diabetes, has hypertension, hyperlipidemia, and he was referred for a couple reasons. He was referred for numbness in his feet and some problem with his hand. And basically, he's had years since the early 2000s of numbness in his toes bilaterally. It's kind of a loss of sensation, but he would have occasional pains in his toes also. And that slowly worsened over decades. The numbness escalated up to just below his knees. He did have diabetes. His A1C was over 8. He was started on a variety of different oral hypoglycemic agents. I've listed them there, and they kind of switch between these. And he also had a history of some back pain dating back in 2012, and it radiated into his left leg. He had an imaging, he had lumbar stenosis, and he underwent a lumbar fusion, and the pain improved after that. Most of our patients, like probably like you, they have multiple things going on. It's not just one thing.
It's
And then,
all things.
yeah, yeah, it's like they can't make easy. So that was going that kind of those kind of problems were going on for a long time. And then more recently, a few years ago, he started having some numbness in the fourth and fifth digit and a little bit in the middle digit on the right hand. And that gradually worsened. He felt that there was some problems with his dexterity in the right hand, but nothing like that in the left hand. And so that was basically his story. He did have an uncle that had some type of neuropathy. There was no other family members with neuropathy that he was aware of, or any other neurologic problems.
So was he 52 at the time of initial presentation or the most recent presentation?
Yes, at the time of the initial presentation.
Okay,
Yeah,
so now we're looking at him being
I mean,
60.
sorry, time of when we saw him.
Okay,
So
all
he's
right,
52 when he comes for the EMG.
38 when it started. Okay,
Yeah, yeah.
all right, thanks. And with this, back in 2010, do you know what evaluation they did for causes of neuropathy? Did they know he was diabetic prior to this, or was it uncovered as part of an evaluation?
That's a good question. I don't know. I don't know exactly what was done for the neuropathy.
Okay.
I think he had diabetes back then. I think he's had it for a long time. And I think the assumption, if I remember, and it's been a little while since I've seen him, I think the assumption was that it was the diabetes.
But I guess we can be reassured back in 2010, probably not a lot of the antibodies we have now or the gene panels and that kind of thing.
Yeah, I don't recall him having extensive testing outside of normal lab work.
Okay. And right-handed or left-handed? Do you
He's
know?
right-handed.
Okay.
Yes. Yeah, I forgot that. Neurologists should always put that.
No, it's okay.
So, all right. So that's the story. And I'm going to just show you the exam too, because I know neurologists always examine patients. So here's his exam. And I'm just going to describe a few things for those listening. And just keep in mind, if you can see this is the Mayo grading scale. So not MRC scale. So 0 is normal for us. -4 is completely paralyzed. So -2 would be like 50% weak. Okay. So on his motor strength testing, in his lower extremities, he had moderate weakness in bilaterally in his toe extensors and flexors. And there was a touch of ankle dorsiflexion weakness and plantar flexion weakness on the right. And then maybe this was more equivocal, some hip flexion weakness on the left. So that was kind of the lower extremities. In the upper extremities, he did have some distal weakness bilaterally, but it was asymmetric and it was much worse in the right hand in his hypothenar muscle and his interossei. That was -3. So he was quite weak, and it was only -1 in his left. He had bilateral thumb abduction weakness, so thenar weakness, pretty similar. And then he had a little bit of finger flexion weakness, a little bit more on the right. And I don't know, and this is my colleague's exam, but I don't know, I can't remember in the finger flexion if it was more specifically in certain fingers or not.
Okay.
And then also there was -2, so about 50% weakness in the right wrist flexion.
And for the finger flexors, are those the deep finger flexors or superficial
I,
finger?
I, I don't know.
Okay.
I don't know. That's a good question. And there's details. So why do you ask that?
With the deep finger flexion, I'm thinking more of perhaps a myopathic process, particularly something like inclusion body myopathy, which really doesn't fit perfectly, but we do have patients with diabetic neuropathy that end up getting an asymmetric presentation of hand weakness that can end up being IBM. Um, and that's just one of the things I was thinking as we were presenting the case, because you told me it was going to be a challenge.
I'll tell you, it's not going to be that challenging. So, but no, I think that's a good point, and there's some bells, right, that ring, bells that go off in neuromuscular physicians' heads. So,
Yeah. And
finger flexion, quadriceps, we think of IBM and things like that. So,
and his knee extensors are spared in this case, which argues strongly against that. But
right, right. So, and he had sensory symptoms, but you're
yeah,
right. That be neuropathy is separate from this.
yeah.
So, and then, um, interestingly, his reflexes were normal, were
Okay.
documented as normal. And again, I don't remember. I only saw him in the EMG lab, and I don't remember exactly if I found that as well. But he did have sensory loss distally in his feet to all modalities, and it was symmetric. And then there was decreased sensation in distally in his hands too, with a little more vibration decrease in the right hand. So that was his exam.
This is a little bit of a tough case. Yeah. So I guess what strikes me is that his hand weakness is out of proportion to his distal lower limb weakness for what I would expect if this had just been progression of his neuropathy. So I'm thinking that we've got a new process, obviously chronic because it had been progressing 3, 4 years, I think, at the time that he came for the last EMG, but something superimposed affecting right greater than left distal upper limbs. I guess it's reasonable to think the left upper extremity weakness is more in line with what we're seeing distally from the neuropathy, but the right is certainly much more than we would expect and seems to involve median, ulnar, radial, innervated muscles, but everything looks predominantly lower trunk on that. So,
Okay.
kind of thinking, could it be cervical radiculopathy on top of this background? Could it be a lower trunk plexopathy that's slowly progressive, perhaps from, a mass lesion or some other infiltrative process? Does he have multiple compressive neuropathies due to a hereditary process? Um, does he have something that could be acquired on top of this, multifocal motor neuropathy, for example? So at this point, I've got a lot of things running through my head, and I can imagine talking through this in the lab with our techs,
Yeah.
our fellows, and deciding, it's gonna be a long, long Friday
Yeah.
out.
Yeah. This is probably the case that would show up in
Yeah.
about 2 hours for us. It's Friday
Yeah.
right now, right? Yeah.
And I didn't mention it, but motor neuron disease, obviously a consideration, limb onset, superimposed upon the other things.
Yeah. And just going back, his history was he does have the numbness in the fourth and fifth digit, right?
Yeah.
So
Yeah.
and that's so and he was so when you see patients in EMG, how what percentage of patients have more than one thing going on?
Here at Duke, I would say 80%
Yeah,
would probably be a conservative estimate on that.
yeah,
In fact, if we only have one problem, we go looking for others, I
I
guess.
know.
But
I was gonna say the same thing. When someone comes in with a straightforward carpal tunnel, I think, what am I
yeah,
missing here? There's got to be something else going on. So,
yeah,
so,
yeah.
so if you were talking, well, let me ask you this, just kind of as an aside, when in your lab, and this is more for my curiosity, with you have techs that do the conductions?
Well, techs do them. We may do them as an
Okay.
attending or our resident or fellow that's in training under supervision, but we do rely a lot on our techs.
Yeah. So if when you have patients and the techs are going to do the conductions, do they talk to you about each patient first before they decide what to do, or do they kind of have a protocol and they just go in and start?
A physician will go in, talk and examine the patient, and then advise the tech on what to do. The tech will typically finish that and come out and talk to us, but some of our techs are really great with their anatomy and their understanding of electrodiagnostic medicine. So they will actually go ahead and add on the thing they know we're going to tell them to based upon the results they have at that point. And
Yeah.
they're really good with that.
Yeah, that's interesting because and I think that's a great way of doing it. For us, the techs will go in first. We
Mhm.
don't even go in until they're done, unless it's a really complicated patient like this. They might come and ask us, "What should I do?" But
Yeah.
they kind of, if it's straightforward and they kind of have an algorithm that they do, and
Mhm.
sometimes we'll send them back in, but um, we don't always discuss the patient first with our techs if it's pretty straightforward.
Yeah,
But
I can think of a time here and there where someone's got a referral for carpal tunnel and no physician's available. They may go ahead and just start
yeah,
that.
okay. So if the tech came and asked you what you would do, can you share like what you would tell them to do in this case?
I would tell them that we're going to start with just our general lower limb neuropathy screen, knowing that it's going to be abnormal based on everything we've heard. So we usually will do fibular to EDB, and if no response, we'll try it to the tibialis anterior, tibial motor response, sural sensory, and superficial fibular, if appropriate. Probably not in this case, because I'm going into this, I'm like, this is going to be a long study. We know he has neuropathy. We're not going to do H reflexes off the tibial because we know there's this lumbar spine concern, and that's really not the main point of our study. And because of that, in this instance, I'd be unlikely to tell them to compare it to the other side right
Mhm.
off straight away. Um, then we would go to the right upper limb. We would do median motor, sensory, ulnar motor sensory. I expect this to be abnormal, especially the sensories. And then we would go ahead and do radial sensory. Um, and based upon my exam that I've done before this, if there were forearm involvement, I might have them do the MAC, medial antebrachial cutaneous nerve in the forearm. Radial motor response itself, I feel like I get more information out of the EMG and nerve ultrasound, so I probably wouldn't do that.
Mhm.
And then I would tell them to compare with the left side for any abnormalities. So this
Okay.
is this is a long
I
study. I'm
Yeah,
sorry.
no, no. I mean, I think that all makes perfect sense. And
Yeah.
the only thing I would add to that, not
Yeah.
change, is I would say bef when I to explain what to do, I would say first take a deep breath, then go to the bathroom, and then go do everything because it's going to be a long study.
We actually keep snacks and drinks for our patients in the lab for this
Oh,
very purpose. Yeah.
yeah. So this is one. Yeah, they're going to have a
Yeah.
party, and yeah.
So
So
we will talk
no,
to the
I think that approach. I'm gonna quickly go through some of the conductions and show you what we did, and we can kind of talk through them. But yeah, and it's always hard. It's we have an approach, but as you're alluding to, it might change depending on what we're
yeah.
finding. Yeah, but going, I think an important point is it's important to go in with an idea of how you're going to approach this patient,
Yeah,
even if it
this is
changes.
going to be a complex study for sure.
Yeah. So, okay, well, let me show you a couple things here. So here's, this might be a little hard to see, but it should be pretty obvious.
No
This is a,
response.
we did
Yeah,
a fibular and tibial motor. We usually do both. No response
yeah.
from EDB or AH. Searle's absent too.
No surprises there. I
Yeah,
mean, 14-year history of neuropathy. Yeah.
yeah. So we did exactly what you said. We did the fibular anterior tibialis, and actually it's pretty good for,
Yeah, so really emphasizing it's quite distal here. I mean, for more advanced neuropathies, we may see that amplitude be below 2 millivolts or even 1 in severe cases. So this to me says, okay, what's going on in the hand is likely to be separate,
yeah.
superimposed.
Okay. So then we went up to the hand, and I'm gonna show you a couple of these. So this the median motor study, and you can ignore this a little positivity here. It's not
Yeah,
perfect, but
that's okay. It's real.
it's real. And
Yeah.
but
So I'm a
yeah,
little surprised because I remember that I think it was a 3 minus strength. So would that be like 25% of normal strength for
well,
the,
APB was, yeah, it was -3.
yeah. So I
Yeah,
actually expected the amplitude to be lower,
yeah.
but don't see a conduction block. I don't see a drop in amplitude that really concerns me that much or any marked temporal dispersion.
Okay.
So I'm a little surprised it looks this good.
Yeah, I am a little too, and
Yeah.
I guess I guess maybe I can ask, or we can talk just briefly, how can we justify or explain a median motor amplitude of 6 and a
Mhm.
weak thenar muscle? It,
Yeah. I mean, I would say, we're stimulating at the elbow. Is there something going on proximal to the elbow that's affecting this? That would be my
yeah,
uh, first thought. And we might get that information from the F wave response. I don't know. Um,
there's the F wave.
and we would definitely expect it to be present with an amplitude that high. How far out does this tracing go, by the
This
way?
is, oh, I cut off the sweep, but I think this is, well, this would be about 5, 10, 15, 20, 25, 30, 35, 40, 45
Yeah,
milliseconds. Yeah, it's at, yeah.
yeah. So it's either way, way out there or completely gone. Okay.
So does that make you think maybe the proximal
Some of
pathway is
the nerve
affected?
root, the proximal nerve may have a conduction block in it. So you may start thinking something acquired the myelinating process. Yeah.
Mhm. Okay.
Or it could be, well, I'll see some more things.
Okay. Or the exam could be wrong, but this is
Yeah.
done by a very outstanding neurologist, so I trust the exam. Okay, here's the ulnar.
This looks more like what I would expect, kind of what I was thinking for the median itself. First of all, we've got this prolonged distal latency in an area that's not prone to have entrapment there, although it potentially could occur at Guillen's canal. The waveform below the elbow is dispersed and low amplitude, and that continues above the elbow. So velocity wise,
It's 18. So
team.
we're recording. We're recording here just for others from ADM and FDI. So two channel. Do you do that, or?
Not routinely. We do when there's a discrepancy in one being atrophied and the other one not,
Mhm.
which we sometimes see, and but not routinely. But
Yeah,
certainly these are equally affected and showing the same problem there.
yeah.
The things that strike me anytime in a diabetic that I see a conduction block in the forearm, I don't get overly excited because you can see a little bit of that in diabetic neuropathy, not infrequently, but this far exceeds that. The velocities are incredibly slow, and I would say even slower than we tend to see in a routine CIDP case. Usually we're getting those at least in the low 30s, maybe high 20s. 18, 19 is really quite slow. But
Hmm.
the conduction block suggests an acquired process, although there are hereditary demyelinating neuropathies that can show conduction blocks as well.
Do you think would you are you confident in calling this a conduction block in the forearm? And the reason I ask is I'm just curious is because the amplitudes are pretty low. They're the distal amplitudes 1 in
I'm
FDI and 2. Can we
I'm
call it
not
conduction block?
I, you know, the way I would write this report was I would report that there is a drop in amplitude of a certain percentage. And then I hedge after that by saying, in the context of severely reduced distal amplitude. And for example, if definitely when it gets below 1 millivolt, I'm in amplitude distally, I am extremely hesitant to call conduction block
Hmm.
because it doesn't take much in the way of having one axon affected
Yeah. Yeah.
to cause that appearance.
Yeah.
But I'm worried about conduction block. I would put it that way.
Yeah. I guess the other thing is, I mean, this patient probably has 2 or 3 things. We can give the patient another thing and say they could have a Martin Gruber anastomosis too.
You could. There was that little, well,
I mean, just because the drop in
yeah.
amplitudes between wrist and below elbow, I don't think we checked for it, but
Yeah. And I mean, you could also say there's ulnar nerve compression that's really terrible at the cubital tunnel or at the elbow, and that's playing a part of it. But what really strikes me is the asymmetry between this response and the median response.
yeah, yeah,
Yeah.
yeah. But so do you think an ulnar compressive neuropathy? Because the
No,
slowing is between well,
I
it's equal,
don't.
but below elbow to wrist. Okay. Yeah. That
I
this
don't, but I'm
right.
just, yeah,
Yeah.
advocating,
Okay.
mentioning all potential
Yeah.
explanations.
Yeah,
So,
exactly. Okay.
and there's
All right.
distal slowing too.
Exactly. Yeah. So these are slow, but prolonged latency.
Yeah.
Okay. Let's keep that in the back of our mind for a moment. And
Mhm.
then here's an
Ah,
ulnar F wave study. And I actually have 2 pictures because I slowed the sweep here.
yeah. So first of all, the F wave's absent, which is not entirely surprising given the amplitude you're starting with. I would have expected to still have found one, but I'm seeing, this kind of uniform response with stimulation, same onset, same morphology that looks like an axon reflex to me. And if you go back a little further in the sweep,
Here.
there's a little tiny one that maybe
Yeah.
you have.
Let's
I can't tell if it's part of the bigger picture, but it looks like there may be
right here too.
several of these present,
Yeah.
which raises concern to me for again, spots of demyelination, remyelination, or somewhere there's been obviously sprouting of
Yeah.
new nerve axons.
I guess those are pretty non-specific, but I agree if you have multiple ones, it certainly suggests some type of nerve problem,
Yeah.
which we know, but demyelination.
Yeah.
Yeah. Okay. So I'm gonna quickly go through the sensories here. Oh, they did inching. I don't, would you have inched that one? I mean,
No, I wouldn't
yeah,
have because
yeah,
I don't think it's a focal single problem in the
yeah,
nerve. It would be multifocal, but here I don't think inching it
yeah.
was helpful.
I agree. I mean, this is again where our techs will go in and do, and this patient was sent for questionable neuropathy. But yeah, it was so slowed all the way along the nerve
Yeah.
from below elbow to wrist. Finding a shift in the latency or a block across the elbow probably is unlikely. And we didn't really see anything like that there. So then the sensories, the ulnar sensory, we thought this was motor artifact. I'm
Yeah.
gonna just kind of go through this because I want to show some other things. But it was absent. The median sensory, you think that's a real response?
I can buy that one. Yeah. I
Okay.
mean,
You don't think
it's
we're
got a,
faking it here?
no, I can buy that. It's got a really rapid rise time and it differentiates itself from the background artifact pretty well there. The digital sense, well, that's an elbow. Okay, stem at the elbow.
This is elbow stim.
Yeah.
This is an antidromic. Yeah.
Yeah. Harder to pick that one out a little
Yeah.
bit, but yeah, distally, definitely there.
Yep. So low amplitude. And then we did do a radial sensory. It wasn't a great study, but the amplitude's low also here.
Yeah.
So yeah, which
And
sounds like
distal latency is the peak latency is good.
yeah,
2.2. Yeah.
yeah. But and then we went over to the other ulnar. So we did compare the ulnar, and that looks really good.
Yeah, it looks what about the F wave for it?
Um, I don't know if we did the F wave. I don't have a picture of that.
I was just thinking, the median on the other side motor, it didn't look bad. It was the absent F wave that was the
Yeah.
issue. Yeah.
Yeah, that would have been interesting. And the other thing that, and we didn't do, might have been to do the median motor
Mhm.
because it was
Yeah.
6 on the right side. And maybe the other explanation why he's weak is maybe 6 is low for, it's technically
Yeah.
normal, maybe low for the patient.
Yeah. Seeing this, I would wonder about that as well. Yeah.
Yeah. So would you do anything else then? I mean, you said you might do the max, which I think is a good thought too. Um,
I tend to be pretty comprehensive in my approach to things. I think I do more in this kind of case than maybe is always warranted because I'm really trying to put things together. Um, I probably would actually start with the Mac on the left and if it's absent, there's really not much of a point in checking for it on the right, where he's really truly symptomatic. Kind of use that approach to minimize testing in patients because if
mhm.
it's absent bilaterally, that's not helping us at all.
Okay.
Yeah.
What about, could you do anything else that would negate the need to do the max in your mind?
That would negate, well,
Like,
I mean, I can tell you what I want to do with this patient
yeah,
now.
I want I want to know what you want to do.
I want to do a lot of ultrasound before I do
Okay, I was
anything
waiting for that.
else. Yeah, I don't want to do any more nerves. If this were in our lab, we would be doing ultrasound pretty quickly.
And I'm going to show you some ultrasound because we did do
Okay.
some, probably not nearly as much as you would have done. But if, what would you ultrasound? I'm just curious, what would you do and how extensive?
I would look at the right ulnar nerve along its length. That would go from wrist all the way up to axilla. I would do the same for the median nerve. We do that by we scan the whole length of the nerve and we stop and we take measurements anywhere there's an abnormality. But we also have predetermined sites that we do just to have some standards to make sure it's done, at these points on all our patients, wrist, forearm, cubital tunnel for the ulnar nerve, epicondylar groove midway between the elbow and axilla, and then the axilla, the median nerve, it's wrist, forearm, antecubital fossa, then midway to axilla. Then I would take a look at the interscalene brachial plexus, and if possible, try to get a look at the nerve root size as well. Although
Okay.
in this case, the nerve roots that could be potentially involved are going to be the most difficult to get an accurate cross-sectional area measurement on.
Yeah. And how long would it take you to do all of that?
Um,
I'm
I
just
could
curious because,
I
yeah.
could do the median and ulnar together within about 10 minutes and probably another 5 to 10 minutes on the plexus and roots, depending upon how the patient's neck is configured. So
Mhm.
short, thick necks take a lot longer than longer, skinnier necks when you're looking at the plexus and nerve roots. So just a little bit more involved. So if you're ever demoing this at AANEM, scan the room for a long,
Yeah,
slender neck.
right. There you go. So
Yeah,
if anyone's watching this that'll be at the next
yeah,
ANEM and you have a long skinny neck, you might
yeah.
be called out. Yeah.
Yeah, yeah, no, like Olympic bodybuilders or anything
Right.
like that. Yeah.
Right. Okay. Well, I'm going to show you a couple things here.
Okay.
So don't critique my ultrasound skills. Well, you can. It's fine to
No,
critique it. I
no.
actually, but we just have the ultrasound on the machines. So
Yeah.
we in our lab don't have a standalone ultrasound. So that's what you're going to see.
Mhm.
And I'm going to show you the ulnar nerve. I'm going to show you two videos and then I'll show you a couple still pictures here. Okay.
Okay.
And hopefully you'll be able to see. It's a little bit choppy, but I think you'll be able to see it. So I'm going to just point this out. I know you know what you're looking at,
Mm,
but
yeah, so you were into the cubital tunnel and the epicondylar groove for the ulnar nerve here, right?
yep.
Yeah.
And I don't know if you just with, again, I know it's hard when you're not scanning and you're seeing pictures
Mhm.
that someone else, but just does anything kind of,
Yes, the nerve, particularly as you start at the cubital tunnel region, it looks very hypoechoic. I can make out some individual fascicles that appear to be quite enlarged. It's hard for me to, I guess, guesstimate the cross-sectional area of this without, um, it looks like the depth settings on this, you're probably on
this
a
is at one.
superficial nerve
Yes.
setting with that system.
Yeah.
So it's big. It looks big to me.
And
And
I'll show you the still cross-sectional areas in a moment.
but um it's not terribly, terribly big like we might
Yeah.
see in some very chronic hereditary demyelinating processes.
Yeah.
Um,
But
but
these
this looks
fascicles, you
good.
think are big? Like
They
you
are
think,
big, yeah.
yeah. Okay.
They're too big, and I don't see any internal architecture in them. I don't see any stippling.
Okay.
And it's important to note when you get up to that ulnar groove, the epicondylar groove, the nerve often looks hypoechoic there, and it can be difficult to make out any internal architecture. So I don't make as much of that,
Hmm.
but gosh, what a contrast between the hyperechoic epineurium and the interior of that nerve.
Hmm. And the scan you would grade at least a B.
Yeah, I think it is an A plus.
Okay.
Did a great job.
All
No,
right.
you can see what you need to see there.
Yeah. And here's the other. So here's continuation more proximally above the elbow.
Yeah, and here I think, yeah, the nerve's pretty superficial, of course, around the tricep area. Oh, yeah. So
Yeah. I
here,
like the, oh yeah.
yeah, this
I
is
was
what
waiting
you
for
want
that.
to see is that while it was a fairly consistent, albeit enlarged hypoechoic appearance distal to the elbow. You could still make out individual fascicles. Now, as you're coming proximally up the arm, you can see it actually change in size. This area is kind of ballooned out, and the internal architecture is very abnormal. You've lost all your fascicular detail there, and there's almost what I would call a smudge signal in the middle of it.
This or a little
Yeah,
later.
where it's
Yeah,
like
right here.
somebody put a fingerprint on the screen right in the middle of that nerve.
Hmm.
And that is something that we tend to see in a nerve that's pretty sick.
Hmm.
And I don't know what it correlates with histologically because we're not taking biopsies of motor nerves and in the upper limb, especially in conditions that are treatable. But this looks clearly abnormal, clearly enlarged. I'm gonna guesstimate again.
Here, I could, well,
This
you can
like
guess.
35 millimeters squared
It's a
up
little less
above
than
the
that.
elbow.
Yeah, it's a little
Yeah.
less than that. These are some of the still pictures. Um,
Yeah. So this is where
that's,
it's a little enlarged because
yeah,
normally this is more the forearm,
yeah,
distal cubital
forearm,
tunnel. Then it
and
gets
then
a little big going
yeah,
into the tunnel.
yeah. So I wrote the number so you can see 14 there.
Yeah. Enlarged there. That's
And
that's quite large for the cubital tunnel,
yeah,
14.
and here I think, as you said, the fascicles, you can see these big
Yeah.
fascicles, and then getting higher, but in the cubital tunnel, I just took a bunch of pictures, just
Yeah.
and then let's see, we get to the groove wasn't that large, maybe
No, no.
13,
It's just
maybe,
a little big, which is kind of the general impression.
and
And
then it
then,
starts to get big.
yeah.
18, and then this one, I think, well, let's see.
Mhm.
Here, 22
Yeah.
is what I
So,
measured. Yeah, that's the,
yeah. I
yeah,
think where you paused it in the video is even bigger than this.
yeah. Maybe it comes out a little bit more, or maybe
Yeah.
I, no.
And there, longitudinal section. Yeah, you can see this focal dilatation. It's kind of like a fusiform enlargement there.
Hmm.
It does not look like it's anything extrinsic to the nerve. If this were something like say, a schwannoma, it would kind of look like a little egg, stuck on the outside of the nerve.
Hmm.
Also doesn't have any fluid around it or any internal mix of truly hyperechoic and hypoechoic signal like you might see in a neuroma. Um, this to me looks if I did, we never ever want to do a differential diagnosis of what's going on with a possible mass lesion of a nerve on just ultrasound alone.
Hmm.
But, it looks a lot like an acquired demyelinating process. Uh,
Hmm.
Certainly can't exclude a genetically mediated one on this appearance alone, but it favors um,
Hmm.
acquired because it is multifocal. It's not uniform in size. There's a lot of variability in the nerve size.
Yeah.
And occasionally, very rarely, I've seen neurolymphomatosis look like this, where it looks really hypoechoic in segments and has multifocal enlargement. But
Hmm.
clinically, that looks more like an axonal process on electrodiagnostic testing and is quite painful for the
Hmm.
patient.
Yeah. And and we know the conduction studies too showing
Yeah,
severe demyelination too,
yeah,
which helps, right? You say you don't want to make a diagnosis just on ultrasound, but
that's right.
we
Yeah.
have that ulnar motor that's velocity in the teens or 20.
Yeah, this
So
definitely makes me think more acquired demyelinating disorder.
are you confident with the enough with ultrasound that, or would you do MR imaging?
For this
In this
case,
case, yeah. Would you look at this?
I'm not hearing anything clinically or on exam or with the seeing it with the electrodiagnostic part that I'm concerned it's anything else.
Hmm.
If you had asked me this 10 years ago, I probably would have said, yeah, I'm going to get MR neurography just to make sure.
Hmm.
But the MR neurography, this is still really small for their degree of resolution.
Hmm.
You can get faint contrast enhancement in conditions like CIDP. And sometimes when you're getting it for the sake of completeness, when everything shows, an acquired demyelinating disorder, the MR imaging can confuse the situation. And then
Hmm.
it leads to perhaps an unnecessary biopsy or delay in treatment.
Yeah.
But I don't see anything about this that makes me want to go toward MR. And I feel like I'm pretty conservative in saying I don't know and getting an MRI. Yeah.
Yeah. Well, guess what was done? An MR.
Okay.
I don't think they trusted my ultrasound. No, I'm kidding.
Okay.
I think just for additional information, perhaps.
Well,
So
your MR neurography there is really excellent. I
yeah,
mean, these are beautiful images. So,
yeah.
yeah.
So just for, so I'm going to show two images, this in the next slide, but this is just tracking the ulnar nerve up, and
Mhm. And look how tiny it is on that MR scan compared to your big ultrasound image.
yeah, yeah. I like
Yeah.
the ultrasound, but if you look here, you
Yeah.
can see the
Yeah.
enlargement of the nerve here.
Yeah. Yeah. You
Yeah.
can.
Here's another showing
And it
the
confirmed it.
hyperechoic and then the normal cut here.
Yeah. Oh,
So
I'm
they,
reading the text above
yeah,
it.
so they said for those listening, a segment of about 9 centimeters of increased size, irregular focal enlargement. They said versus cystic change, but I think, like you said, we can be pretty
Yeah.
confident it's not at several fascicles.
Yeah.
We didn't scan the median nerve. I think your point is a really important one, and we're certainly not as experienced in ultrasound as, and don't do it as much as you guys do, but I think with the median nerve, we probably should have looked up there and looked at the plexus. They
Yeah.
didn't see any abnormality in the median or radial nerve on the MR, though.
So the latest CIDP criteria, median and brachial plexus, nerve root are all part of the supported criteria. But kind of looping back to something I said earlier, you know, we try to not do unnecessary testing. You got the answer with doing the ultrasound, the information you wanted with doing just the ulnar nerve. So anything
Yeah,
else would have just been extra.
right, right. And I think your point about the median nerve is important. That I don't think we didn't do enough to fully explain, to fully exclude, even with the MRI not showing anything, to fully exclude a proximal median nerve focal or some fascicles that are blocked
Mhm.
to account for that. So, all right. So are you, and then just to finish up what we did do some needle exam. And again, it's always in hindsight, we learn from our cases. I didn't stick the APB. If I would have done this patient now, I would have. I think the thought was most of that was his neuropathy, but he did have changes in the ulnar muscles, so reduced recruitment in ulnar muscles, pretty severely reduced, and he had some long duration motor potentials distally in the leg. So that fit with neuropathy and a problem with the ulnar nerve there. His EIP was normal.
Why did we think he had finger extensor weakness and a normal EMG?
Yeah, I don't know.
I mean,
I don't
we
know.
see this all the time. I'm asking rhetorically, this happens to me on a weekly basis where the
Yeah.
muscle is normal on EMG, yet there's weakness there.
Yeah, I think that's a good question. I mean, first of all, I would say I always think, even after having done this for decades, that sometimes it's hard to totally judge finger extensors because they're always able to overcome them. But the other thing is, with recruitment, with I always think if someone's weak and it's due to a lower motor neuron process, there should be reduced recruitment.
Yeah.
But I certainly have had cases where I'm just not seeing that reduced recruitment. And I think it may be the higher threshold motor units that are lost rather than the low threshold motor units. So when we have them activate, so there are 3 or 4 motor units firing, the firing rate's normal. And unless we have them activate really strongly where there's kind of an interference pattern, we don't see the reduced recruitment. So I
Yeah.
think that can happen too. And I've had patients that I've scratched my head and said, there's got to be reduced recruitment. I'm just not seeing it
Yeah.
here. So
Yeah. We had someone like that earlier today. So it's fresh in my mind. Yeah.
yeah, yeah. So okay. So with all this, at least with the
Yeah.
information we've done, do you think, we know he has this chronic neuropathy, forget that didn't seem to be demyelinating. And then he
Yeah.
has this ulnar nerve, these changes. Do you think this is CIMP, like chronic inflammatory demyelinating CIDM?
I think that, yeah, I do. And this would be what to me, looks most like what we used to call Mad Sam or Lewis Sumner variant, that it's asymmetric upper limb. And, but it's always so hard to know in somebody that's got pre-existing chronic neuropathy, particularly diabetic neuropathy. So I would probably, if we look at doing CSF testing, he's very likely going to have elevated protein levels from his lumbar fusion surgery plus his diabetes. So I'm not sure how much that's going to add.
Mm-hmm.
So I probably would go ahead and start treatment with setting some expectations over what we're expecting might improve.
Yeah. And would you treat with IVIG?
Yeah, I generally in this scenario would do the induction of the IVIG at 2 grams per kilo and then treat him again for months 2 and 3 and then
Mhm.
reassess him clinically and with nerve ultrasound.
Mhm. Okay. Well,
We
oh,
we
go ahead.
probably throw that ulnar motor back in there just for fun too, but
Yeah. Yeah.
generally what I would do. I don't know if it's the correct thing, but that would be
Yeah.
my approach.
Right. Yeah. So I'll just tell you that he is about to begin IVIG. That was the approach here,
Oh,
thinking
good.
this was a CIDP
Good.
variant, and he's going to be treated, I think, maybe even this week or next week. So I don't know what the answer is. I don't know if he'll respond, but I think your thinking aligns with what we were thinking here.
That's
And
encouraging.
it's always good. Yeah.
Yeah.
It's good for us to know that we're not totally off track here.
Yeah,
So,
I guess the only other point I would make, I could see someone saying, why is it, what about multifocal motor neuropathy? What's that like on ultrasound? And with the nodopathies, multifocal motor neuropathy and the nodopathies with contactin, neurofasciin, we don't see this kind of enlargement on nerve ultrasound. So even
mhm,
if you didn't have such profound slowing on that ulnar response, the
yeah.
ultrasound doesn't really match with it.
And I think that I mean, you're familiar, I'm sure, with the ultrasound literature. There was a recent paper, I believe, on looking at some of there have been probably many, but on CIDP and MMN. I actually, I
Yeah,
think this one, are you familiar with this paper
I
by?
am.
Yeah.
Yeah. And I did know Professor Podner, really, he's
Yeah.
excellent. Yeah.
Yeah, and they looked at, this isn't a journal review, but this looked at the length. I thought it was interesting, the swelling length in basically the MAD SAM and multifocal motor neuropathy, and the length of the enlargement was larger. At least that was one point of this, I believe, in the MAD SAM patients.
Yeah.
24
And
uh,
that's something their lab does. He has a really strong background in electrodiagnostics and has published a lot on inching studies. So,
mhm.
and that's
Yeah,
how he got into looking more at the length of the nerve swelling, which is something we don't routinely do unless we're looking at a mass and doing
right.
surgical planning.
Yeah. Yeah, but it was interesting because then I looked at our radiology report and they said, well, it's 9 centimeters. And I thought, well, okay, that doesn't fit with either of these, but it's still
Yeah.
the multifocal nature, I think,
Yeah.
does with it. So, and then the other thing I was going to show, which I think is always interesting, is you're probably familiar with this because you wrote it, this
Yes.
editorial. This is in 2014
Yes.
where the summary back then was it's apparent, or where is it that uh,
Is it
basically that there's a utility signals a new era for peripheral nerve ultrasonography here. right? And this
Yes.
was on studies on CIDP. And then
Yeah.
there was another editorial recently that basically says that ultrasound shows promise as an adjunct to EMG, but I think we're past showing promise. I
Yeah,
think
I
it,
mean, we're part of the diagnostic criteria. We've got an AANEM guideline for carpal tunnel syndrome that shows level A evidence, which I always point out we don't have for nerve connection studies in carpal tunnel because it's just not developed in that way. But
yeah,
no, for us, it's an essential part of what we do every day.
yeah.
And
So
again, never replacing, always, adding.
yeah, exactly. And I guess to ask one final question, if you're to summarize this, if you had tips or advice for someone working in a lab that has ultrasound when they're assessing patients with neuropathy or CIDP,
Yeah.
is would your advice be do what we do all these nerves, or at least do one nerve that's clinically affected and take it all the way up? Or, not every lab has the ability and time to do every nerve,
Yeah, and we don't either all the time, to be real honest about it. We know work is ideal, but always scan the length of the affected nerve. And if you can, try at least to do the median and ulnar both in that limb if only one of them is affected. And again, this is not just for diagnostic purposes. Um, when you capture these patients early in the course, you will see those nerve swellings improve. And they will, there's been case reports and we've seen it in practice that it will improve before the nerve connections do and herald improvement in the patient as well. If it's chronic, they're not going to change because it's a structural change. But yeah, I would say at least do the affected nerve along its length. If you can only do part of the affected nerve, choose the segment above the elbow.
Okay. Yeah, I
Yeah,
mean that's a great point, because not an area that's kind of prone to enlargement from entrapment too.
yeah,
So,
yeah.
well, good. Well, I had no doubt I would learn a ton from this hour. And
No, this has been fun. I learned as I went along too. So and it
well,
did feel a little bit like the oral board exam. Yeah.
yeah, well, I hope there wasn't any beads of sweat. I was the one sweating here because I was showing you my ultrasound. So,
No, it looked
but
great.
but no, this is great. I'm sure the people watching this and listening will have learned a ton from you and will continue to learn from you. And I really appreciate you taking the time on your Friday afternoon to talk and chat. And this has been great.
No, thanks. It's been a lot of fun. Thanks for inviting me.
All right. Well, we'll see you soon. What an absolute treat and joy to have the opportunity to learn from one of the world's experts in neuromuscular ultrasound, Dr. Hobson-Webb. Is so knowledgeable. It's great to hear her approach, her thought in patients with some of these unusual mononeuropathies or CIDP. I think it's really wonderful instructional information about how we should scan, how extensive we should scan, what we should be looking for, and how we follow patients with possible CIDP with neuromuscular ultrasound. And it's clear that with her work and others' work, that we're really advancing in the field and utilizing this as a supplemental tool to standard electrodiagnosis. And I'm even more happy that she gave me an A plus on my ultrasound scanning abilities. I don't think I deserve that, but I'll take it from her. So I hope you enjoyed this episode. Have a wonderful day or evening. Bye bye.